Assalamu alaikum. Today we are seeing another transurethral resection of the prostate. This patient had undergone TURP around 10 years back. He was totally asymptomatic, but slowly and gradually became symptomatic with bladder outlet obstruction. So conservative management was tried, but his flow rate did not improve much. And on ultrasound, his prostate weighs 80 to 90 grams. So we offered a cystoscopy and then proceed along with the consent of transurethral resection of the prostate. So these are the cystoscopic findings. We have performed cystoscopy, and the findings were that the bladder neck is quite open, the urethra is quite normal, but there is a huge right lateral lobe which is completely occluding the prostatic cavity. So we have now planned for redo transurethral resection of the prostate. Here we will try our best to remove the symptomatic lobe completely, and also not bother with the bladder neck because it is nicely wide open, covered by the mucosa. So any fiddling with the bladder neck may lead to bladder neck stenosis. We do not want to have any complication from this redo transurethral resection. Since the patient had been on the 5-alpha reductase inhibitors as well as alpha blockers for good 1 to 1.5 years. This can be clearly seen from resection of the prostatic lobe, because there is minimum vascularity, and we can cut the prostate lobe, the right lobe, just like cutting the cheese. But important thing is that a part of the lobe is projecting anteriorly, as well as it is coming beyond the veromontanum. So my aim of doing this transurethral resection in this patient is topmost the symptomatic relief to this patient, and number 2, avoid any complications, especially in the form of bladder neck stenosis and urethral stricture. And last but not the least, to avoid any incontinence, because I may have to resect some area which is coming beyond the veromontanum. But I will try to do that as much minimum as possible. The rest of the resection and its principle remain the same, as we have already discussed this transurethral resection of prostate previously in an educational video. However, these were the few points that I wanted to highlight. One was the openness of the bladder neck. Secondly, the advantage of giving 5-alpha reductase inhibitors for 2 to 4 weeks before resecting a massive prostate, and avoidance of any complications. And the other important thing that I wanted to mention is, as in the previous video, the patient was young, he was married twice, and he did not want erectile dysfunction, and especially retrograde ejaculation. So we did the minimum resection possible, but here the case is different. So we will try to resect this right lobe completely as much as possible. This means that we have to dig deeper into the prostatic tissue, and we may resect the prostate very much near to the capsule. So here I would like to demonstrate. At some point you will be able to see the arrows pointing towards an area which upon application of the coagulation or cutting current or the diathermy leads to severe contraction or strong contraction, I would say, instead of severe, of the prostatic capsular fibers, because there are muscles in the prostatic capsular fiber which upon electrical activation can lead to strong contractions, and majority of the times this contraction will mark that you are quite near to the capsule, and after this contraction you need to be extremely careful. As you saw earlier in this procedure, we were taking deeper and bigger chips of the prostate, but after certain point we will take shallower chips. Here the edge of that lobe which is hanging from the anterior aspect is visible. The point that I want to emphasize will be clear once you see what happens after application of the current near to the capsule. So beyond that point, there are two things. One is the point that we are very much near to the capsule, so we need to be careful not going beyond that, because going beyond that, a complication can happen. The capsule can come onto the loop, onto the cutting loop, and get ruptured, and hence a rent in the capsule will lead to severe bleed, which at times is difficult to handle and control. And in that case, we may have to abandon the procedure and also place a catheter balloon under fluoroscopic control in the prostatic cavity rather than in the bladder. But the positive thing about it is that it shows the completeness of our resection. So a satisfying contraction this is. I hope you get the point what I wanted to make. So we are very near to that point now. So completeness of the resection can be seen two or three ways. The small black dots, which are calcified prostatic glands between the adenoma and the true capsule, they can be seen very clearly all around this cavity now. The second thing is more stronger spurts of blood vessels. It also shows that we are quite near to the capsule now. And the third one is this strong jerk or contraction of the prostatic cavity. All these 2, 3, 4, these things, they show the completeness of resection. This is a mild enlargement of the left lobe as well. It does not need much of resection. However, since the patient is now on the operating table, we take advantage of this opportunity to resect this enlargement as well, so as to give him a better symptomatic relief. And also in the future, as the patient is fit, this lobe may also enlarge, giving him symptoms in the next 5-6 years. So resecting it would be good, and also we'll get some tissue for histopathology. although the PSA of this patient is within normal range. I'm taking care here not to resect the bladder neck fibers. However, I'm trying to make prostatic cavity which is enough for a good flow. Now resecting the area near the veromontanum in a circular fashion. I'm not going in or out. I'm just keeping the resector scope in the same place and resecting the area and moving in a circular fashion from above downwards or from below upwards. This is the way how you resect the area near to the veromontanum, and also try to avoid over resection. But this lobe is coming beyond the veromontanum, so I'm pushing this lobe inside the cavity and then applying diathermy there, rather than applying the diathermy beyond the point of veromontanum, which may cause incontinence as well as may make the patient prone to develop bulbar urethral stricture. So we are keeping the aims of this transurethral resection in our mind all the time while performing the procedure. Mind you, transurethral resection is a procedure. Here you can see that jerk now. Yes, this one. And again. And again. So try to avoid taking deeper chips when this happens, because you are not moving in the loop, but the capsule is coming onto the loop, so this will lead to complications. Again, we saw that strong contraction. So the point is that prostate is a transurethral resection of prostate is a surgical procedure for symptomatic relief and for taking histopathology for any diagnosis. It is not a radical procedure, so try to avoid exposing the capsule as much as possible so that bleed does not occur. Post-operative clot retention, the chances are minimal. And when the catheter is removed, patient usually, if the capsule is exposed, usually the patient has symptoms of frequency, nocturia, especially pain while micturating, and urgency and urgent continence for a longer period of time as compared to those patients in whom the capsule is not exposed. And exposing the capsule also leads to contracture of the prostatic cavity. So try to avoid that. Try to leave some tissue along the prostate so that patient is better symptomatically instead of making him symptomatically worse. Thank you very much for watching. I hope you got the points which I wanted to emphasize. Thank you.